morning. How you doing? We have to change to this side. Life. Joe Welsh. I haven't met Joe Welsh yet. For some reason, my screen. There you go. I can't get it to work. I've got you. There you go. Look.
You're training when you have expectations of doing good medicine.
I think, yeah. Just got to change.
And that way, they give more time for the children. Oh, yeah. People. I got talked off the left.
Oh, are you kidding? How many was yesterday?
I think most of the people that were here yesterday was staff.
Yeah, we weren't staff.
Now we're
We actually have audio. The links on the website work today for the.
Which door should you see?
Yep. To myself all the time. I'm like, thanks, pass me. Thanks for caring.
broken down and approved by like scenario. But
That's
it's
awesome.
Not, the expectations, each phase is broken down. Notice this.
No, I like that a lot.
And then,
I know yesterday I was kind of going,
so
I was like, okay, I guess I'll try to think of a
understand from like the teaching aspect, like we just wanted you to do all that, so like
that
don't
was
feel
my
bad.
yeah that was my first something on the fly.
And it's one of those like.
And we don't. Mine was
something.
not
You're
that
just
great,
gonna
but you
start
could make it.
making up
Where's Aaron at?
Huh?
Where's Aaron at?
I texted him.
It's gonna be fantastic.
Sean
I was like, what did I think I had?
schedule, but I had 100 different things to do.
Yeah.
And the entire week, all of a sudden,
Next day.
he took my shift yesterday, and so I wouldn't even known it. But she texted me. Usually she'll.
Sometimes it's, as far as like how many shifts there are, they're begging for like people to take over. Please don't go.
Well, you guys are just leaving shifts open though, which is feasible.
Yeah, I'm gonna, like I said, I'm.
Some more chairs so we can get some stragglers if they come in. Well, started in EMS back in 2007. Lifesavers is Rachel, and there's all these small, wonderful classes being hospitals. That's not very helpful either. So the goal is kind of, we want to get everybody to get more sim than sitting in lecture stuff too. I'm really doing some EFASTs, looking at cardiac squeeze. I want to get the really good paramedics and the advanced EMS. My goal is to sit in the back and play with my toys while you guys give the lectures and learn. But there's a newsletter list at the bottom of the. So we were just talking about KPEC, and we're going to get hot. Just be respectful and try and clean up for the firefighters up here as well. Back home to Mississippi.
We're faculty there at the hospital, and hopefully a medical director for a couple of the EMS services.
So we've got a
dark maroon riding around on scene. So, yeah. So everybody's got different protocols. This is just reporting severe alcohol intoxication, 110/70s, a little tachycardic at 115, respiration 16. Way that we most commonly do, and all of that soft tissue, including the tongue, will kind of fall backwards and obstruct the airline as we possibly can. I chose to notice this patient or this person has got them kind of further. First off, it's a nice handle, right? It's a lot easier than just grabbing, especially. So that can also tubing. We know it. We look is. Any unresponsive patient that you get, a bunch of vegetable soup. So we don't have a ton of options, but one thing that I do when you definitely need, a little bit more than the Yankauer King. So OPAs, It's going to be unresponsive. Put it upside down and measure it, the lips to the earlobe. So they're don't use these in patients who have a lot of trauma to the face, or you do not want to do that. Properly. All right, so you appropriately address this patient's airway and his.
Aren't used that often to get really good improvement. Like I feel like they're actually very useful tools, and it's something I think it's such a lowly tool that we forget about.
Post-ictal patients, like post-after seizure, where you check their post-swell, particularly that airway, and then
The swelling and the bleeding, that's a great point.
Complaining of shortness of breath. States she was tired, getting up to pee all the time. So when I was a paramedic I learned some of the medications, especially through working and just seeing them all the time. I know some of the basic dosages, but sometimes it's a lot better to try to kind of look at some of these medications, learn the dosages, learn what the standards are, learn what a high dosage is. For Bumex, it's a diuretic similar to Lasix. So the conversion is 40 milligrams of Lasix is 1 milligram of Bumex. So for this patient, she's taking 80 milligrams. So that gives us some good information of how severe her heart failure is. That's a pretty hefty dose of diuretics to have to take every day. So when you stop taking those, or as a patient that I had the other day with switch to a quote over-the-counter diuretic. I have no idea what it was. So on physical, she's the level of the groin, and she's got rails noted throughout. What do we want to do for this patient? So what does the alveoli get basically put underwater? So you put a bunch of pressure in there and you try to stent those alveoli open. Sorry, that's a tongue twister for me. So what that does is it allows for better gas exchange, allows the alveoli that were not working earlier to be able to participate in gas exchange. It also stents them open and makes it where it's easier to actually initiate a respiration and actually take a breath in. That decreases the work of breathing, and eventually it stops them from eventually tiring out. So CPAP, it's a great adjunct. It saves us a ton of intubations. Who does it work for? So the best evidence is for these patients. So COPD and CHF are going to be based on past. It works great for asthma. Near drowning is kind of the same thing. It's going to be pulmonary edema, inflammation, things like that. Yep, that's absolutely on the list.
Or not awake enough to be able to even.
Yep, like they're smothering, and you come at them with a mask and try to put it on. A lot of times with the CPAP. Obviously, if they're unconscious, that's not conscious.
I sleep with a CPAP.
Yeah. So in this fully assess their airway. So if they're
Similar to if they're like if they're paralyzed.
because these masks, it's, you have like your non-rebreather mask, things like that. If they puke, that's going to run out of the BVM, or you're just going to go ahead and tube these patients. Weird. Sometimes you can have a really tough time getting these. So when you increase the positive pressure insulation, that includes intubation, you're going to see a slight decrease. So how to use it? Are they getting worse? Status is not declining, that they have. I like to start low and start them off at 5, usually get better. Their sats will pop up. So if you start off at 5 and you don't really see.
do you recommending titrating the increments to 2.5?
So most, yeah. So have too high of a pressure. These patients are not able to because I'm choking them, or are they getting worse because they're clinical.
Get used to the mask being there. Sometimes it freaks them out having a lot of getting like.
All right, so case 3. So we got a 22-year windshield. So what does this see starting on the windshield? You know that he took a pretty good header into the windshield. I'm sorry. Head injury, yeah. It's one of the warm shocks. So it's one of these. You'll see these patients that have, as far as clearing this patient's airway, that somebody that we're worried about there we go. So we'll talk about first lectures in medical school and any other spinal cord levels of anything else ever. But so what we're gonna try this. I'm not very PowerPoint savvy, so So what we'll often see is what's something called paradoxical breathing. Go to this patient is trying to use other muscles other than their diaphragm. The diaphragm is kind of being pulled upwards instead of the normal expansion that it does downwards. Yeah, so anyway, so you see a patient, like I said, you see somebody like that, it's extremely concerning. They're very strict C-spine and spinal okay, and their respiratory drive is all right. This might be somebody that if they are paralyzed, then they're not, if they vomit, they're not one of the larger priorities. Can get a video scope and a hyperangulated blade to try to manipulate their toxic, ineffective ventilations. Eventually you just have to place an LMA and take them to a U. Always scary when you know that they have some sort of a C-spine injury and you know that somebody's going to have to take their airway. And yeah.
Don't have a gag reflex, but just kind of stop it there so you don't cause any more problems.
Blood pressure up anymore. So basically the tiny little tube that trying to resuscitate them a little bit, especially if you have to give them, if you have to do like an RSI.
And you kind of explain to them and watch that process and see how things change as you guys. But I love, those are wonderful.
I'm an older medic, so I really tube a lot of people in extreme cases. The standard anymore. It's a lot more risky to do intubation.
Resuscitate them. I want to go off and, but I'm trying to, yeah, they will decompensate in our.
It's hard to make trauma surgeons do that too. They're attacking the old paradigm baseball and that's so it's not.
All right, last case. So,
Ask permission.
How obese?
huh?
How obese?
You can get your
Do you want to wrestle them? That might work.
impressions. You start doing CPR, start doing it, and as far as the airway goes.
Oh, you're going to get in there, you're going to go in there. We don't.
Good.
We don't use them. So obviously you're going to go while they're doing compressions and start running the code.
Okay, yeah.
And then provided that.
About a couple of the things that we can do to try to get that obstruction out. It really just kind of pulls the whole picture together. Nobody's having a good time in this picture. Well, they can, like I said, decompensate and die in just a couple of things in tandem, but trying to just figure out, where the obstruction is. Can I get it? What else? After you've tried the Heimlich, you've tried your chest compressions, you've got to go in and try to get this thing squish and get around. You're trying to pull it off. It's just breaking off in pieces the entire time. Starting to sweat. If you can't get the obstruction.
I mean, I've had a few over my career. I can get it up enough, but in order to completely get it Yonker or decanto or whatever and capture the obstruction
Yeah.
and then pull it out the airway.
Yeah.
But these people are still awake.
Yeah.
They weren't,
Yeah, this. That, because they can still assist you with kind of trying to cough it up and things like that, and so that's an obstruction and things like that. Then it's kind of quickly move on. You can try to see if go in like under laryngoscopy, like you have your McGills. You can try. It's not successful. Actually pulling the trigger on doing a field crike. This is the one that Metro uses. I don't know if everybody's using an actual piece of equipment, but obstruction. Obviously, this is not a procedure that is done very common. What you're doing, so go over this, once every couple of months to get this patient criked, and just kind of mentally rehearsing those steps so that when you crike him. Anybody got any questions about any of this? All right. So here's my contact info. Like I said, I'll be with all of y'all. I'm pretty sure I will see most of y'all at some point over the next year. If y'all ever have any questions or anything, certainly feel free to contact me or just catch me on scene. Okay. Yeah. So we'll talk about these pictures. So this is another. Do not put things in people's noses if they have skull fracture or if you're concerned about one. This is a feeding tube, an NG, and went down into the spinal canal. And for this particular patient, they did just shows it in the midline and kind of where it needed to be from that it's in the spinal canal. So they started for this patient, and the top one is, I have no idea why you would ever intubate somebody through their lower jaw, but they did. And then this other one was a intubation on somebody who had cancer, do a surgery, and they're like, there's a hole, we'll just tube through it. So I don't know why.
Thank you, Dr. Dana. Appreciate it. We're going to have Amy Ball from our not ours, I keep saying our, from the transport team. Transport team, she's going to give us our next lecture.
Do you need this?
Yes, please. You can plug it in. There. Should be good. Yeah, that should work for you. I'm sorry. As long as there's glucose in the tube feeds, it should be good. You're feeding the brain what it needs, right? Just hiding on a different page.
It is. Likely I'm illiterate when it comes to that one. There we go. I have all kinds of lectures.
No, it's all good.
I have a pediatric potpourri one.
Oh, perfect. And then you've got a
Up here?
clicker.
Amy Ball. I am, so a lot of people, I know a lot of faces in the crowd this morning. It's funny, not today. No. About the pediatric and neonatal airway, it's something that we spend the least amount of time on when you're in class. I have no disclosures, except I work for Norton Healthcare. We're going to talk about how to bag mask. Let that salty paramedic tell you that it's not, because it is. He was like, they're not different. And I said, I beg to differ with you, sir. Airway first. So when you think about a neonatal airway, they have to come out and be flexible and bendable and pliable to get into the world. Vocal cords are slanted. They have the very compared to the rest of their body.
Of course.
So suction, you've got to clear that. Not a standard of practice anymore, but because we want to clear that out of the way. Fine until around 24 months of age, and so I think it can be hard to distinguish between their tream. Is we like to put a feeding tube or an NG down first, and kind of their mucous membranes are really loosely. It might not be so funnel shaped anymore. It actually they're. So cuffed ET tubes on all of our patients. So again, the toddlers' heads are big. So infants still obligate nose breathing. They do have large tongues. So when you think about how you're going to take the airway of a neonate or those smaller very well, and so, but you want to use that for breathing. So we'll always pay attention to what access. So can you see their ribs when they breathe? Little divot right here between their clavicles. That is something. So what makes that PD, right? So what do they like to put in their mouths? Everything that's small. String cheese choking over at Clark. Great cutters now, you know, they sell those fancy things on Amazon. It was on a transport. Say the names of places. So you can guess where those places are. But, oh, it was Lake Cumberland. Patient down there. We were on our airplane flying back, say something, and as she turned, the patient set up at the same time. Then do that. You don't always have to. Montgomery, you know that she likes to pull her glasses down and look at you in the patient's airway, and it was like a plastic piece of packaging for that. It is a surgical emergency. And they don't just have to be toddlers to swallow something. Or we've had a button battery ingestion, know how many they think they swallowed, and we need to go. So, patient, there's 4 key components that I want you to keep in mind. So so there's actually a weight on the look at it. It will actually say if it's a neonatal ambu bag, it will have a weight limit on there. If it's a limit is. So pay attention to that. On these patients that are obligate nose breathers, we don't want to do things like that. So we measure from the glabella, sniffing head out of the way. And we want to straighten out that airway, maybe give a little bit of cords. That's actually to even back. Get them in that sniffing position, shoulder roll, shoulder roll, shoulder roll to bag mask ventilate a pediatric and neonatal. But then don't smash it to their face. You want to do more of that jaw thrust. Get rid of that occlusion with that jaw thrust. So bring their jaw, we want to 1, 2, 3, breathe. So we want to aim for about 30 breaths. You would do CPR on a newborn. 1, 2, 3, breathe. So paying attention to how fast you're breathing, not only your ambu bag, pay attention to that. So on your neonatal patients, we have to have that. So keep going to automatically open up that air. We keep washcloths on all of our trucks so we can get those neonatal patients. Size matters. And that's probably airway obstruction and lower airway obstruction. So what's geo airway to just stint them open a little bit because they're so hypotonic. They're real flaccid. And then traumas and burns. We also have to think about infection, meaning epiglottitis, and we're seeing more and more of those things, right? Because people aren't vaccinating, et cetera, et cetera. We can talk about that, not here. So, however, we have to think about Norton Children's because it's a surgical emergency. We need to. We've transported 2 in the last 6 months. One, we put a super because it was safer because we could bag the patient safely. More important to be safe. Now, did the nurse say in a little prayer every single minute? Even worse. Back and then pull back and then watch it drop. And absolutely. So always think about you can bag the patient until you get to Children's. Maybe that's the safest and best. Mom says, hey, it's the middle of December, but when we walk outside, it goes away. But then I come back inside, working cough again, right? Well, relaxes. When you come back in the house and it's so warm, that airway, steroids are a great option for things like epiglottitis. If it's mild, you're not going to hear stridor. Moderate airway obstruction, then you're going to have stridor at rest. Maybe not the suprasternal that we talked about right here at the clavicles, but maybe status. You're going to see that suprasternal down. So what is that? Asthma, foreign bodies, which we actually picked up a teenager who was walking down the hall and chewing on a thumbtack. His buddy walked by, smacked him on the back, and he went, and he had a thumbtack sitting in his bronchial. And we had to fly him back to Children's so that he could have a bronch and have a thumbtack pulled out of his bronchial. Thank goodness it was pointing up like this. It wasn't pointing like this. Yes, Donna has a picture, so. Yeah. So even teenagers into their airway. Masses is the difference between the two. Inhale chemicals and burns.
On that incident, did the majority of them that were taken to Brownsburg that while it was occurring? So
Yeah.
The three children they put.
Yeah, we transported the 3 that were intubated, so.
Yeah, they were doing a swimming lesson. So when the parents realized what was going on.
So again, you're duoneb, and so it's 2.5 of albuterol. We also use magnesium terbutaol via MEPI. And so when you give, there are risk factors for severe bronchiolitis. So less than 12 weeks in, start thinking some type of bronchiolitis. And then risk albuterol inhaler this month. We hear that all the time. History of intubation, or if they've been hospitalized or in the ED in the last year. If they have food allergies, or if their PCO2 is greater than 50. And then bronchiolitis may actually respond to albuterol, and typically it does not, but it may if the patient is over a year of age and they're RSV negative. And then we can always consider heated high flow, BiPAP, CPAP on these patients. We use heated high flow. It's saved us from intubations. Our intubation rate has plummeted because we use heated high flow now. And then real quick, the pediatric assessment triangle, the bane of your existence, right? So we're only going to talk about airway and appearance because that's our focus today. So just a quick little mnemonic. So when you're thinking about airway and appearance, always think tone. So is your baby hypotonic? Are they stiff and rigid? What do they look like? What is their tone? Instructiveness. Can the patient follow instructions? Are they alert? Is it a teenager who's alert and oriented? Is it a baby who's looking around? Toddler who has stranger danger? Instructiveness. Consolability. A nonstop crying baby is not normal. It's not just that they're hungry or they need their diaper changed. That is not normal. So are they consolable? What do they look like? Do they look like they're breathing with their abdomen? Do they have nasal flaring? Are they trying to over? What do they look like? Sentences, then they are in trouble. Always think about how they're talking to you.
The research is not real solid for it, but I've used it over the years.
He said nebulized bicarb for inhaled chlorine.
Control do your best. I would have somebody call poison control on scene. And SDS is already gone and XYZ. But I have used bicarb.
It's been gone also for quite a while.
Yeah.
If you guys want to take just a quick few minutes, I know we're getting close.
Because Kappa had to speak for an hour. So I cut like a lot out of it. So I just kind of.
Whenever we start with 30-minute pizza here and the speaker in there. And then they'll.
But if you can go over there. And now it's actually working.
Nick will be in here, so we only need you both to do the same week.
Thing I got from feedback yesterday was they're like, we thought we did something wrong because he coded.
Thought maybe you were taking a nap.
Oh no, I was. Hey Trader, what's up? How are you, brother?
Trader.
Look at that.
Wow.
Yeah.
Okay.
Oh no, I wore those.
Windows were tinted because of how dark it was outside. And I looked over.
Oh, I know.
You have to see them run through it.
I didn't get a chance to yesterday. I want to see it.
Whatever it was, do it.
He is.
I'm working on it.
He is. In Kentucky, if anybody tries to take him. Nobody tries to mess with that.
Where they're put my body.
Nope, theirs.
Squirrely
Those
son
are
of a
the
bitch.
colors.
But
Don't even
then
mess with that.
I'll
Toby will lose his
donate.
first.
Yeah,
that's
it does. Metro Police doesn't know what to do with it.
Talk about it in a second.
But given a lot of credit for it. Most of them just like to shoot the Narcan up the nose and not fall hard. Like, I'm going to shoot that Narcan up and she's
Rise up, I'll be banging low. Because
It's
I talked
it's
to
concrete. They call it concrete.
Or
And if you look at it, it's got that gray, like that on the dealing of child's coldness.
I love when they tell me how much it is. Oh, that's such a cool information.
No funny, but I'm the best place to find.
Time to roll.
But
All right, guys, we're going to our last lecture drill. Guys up in the we need to do regroup focusing.
Yeah, we can.
Our escape room. So we're going to switch it up and do in the high fidelity ambulance simulation. Any questions or concerns that come up while we've been?
My face looks somewhat familiar. Worked at Metro back about reoxygenation, how we can improve it, and some really common mistakes that reoxygenation is, how it works. Recognize some of these pitfalls. This QR code. Not do that when it works. See the first question, what is a word that comes to mind when you think about pre-oxygenation? Any word. This is just kind of a warm-up. There's no right or wrong answer. You'll see it at the top there. You can go to menti.com and put in menti, menti.com, and just put in next day. Stealing my thunder already. High flow position. So let's kind of start with what is pre-oxygenation to do this. Well, it's all about increasing the safe 88-90% depending on where you look at the literature. It seems like they just tank. They start going. But this is a real physiologic thing. It's all about how the your pulse ox is going to be delayed by about 30 to 60 seconds. And I decide I'm going to push a paralytic on you right now and make you stop breathing. So we're doubling our time. Now, hopefully we're not intubating in the truck somebody 1 minute and 2 to 3 minutes, but those minutes really count, especially in these sick patients. Take the non-rebreather off, you put the blade in the mouth, and he drops from 97%. Let's talk about a few things we could have done differently. No, it was cool. That's okay. Your equipment's ready, or be honest, you don't really think about it. You just...
young and, oh my gosh, you had to have that 2 to 5 seconds we need to think for you.
Yeah, yeah.
That too.
For at least 3 minutes, or 8 times the oxygen. I'm surprised nobody to do that full 3 minutes and get past that 100% point. Work. Why do we need to get above the 100% mark? Well, we're working in a specific here. Y volume is going to be your lung volumes, X big spike. This is you asking the patient to breathe out as far as you possibly can. Lung between just your normal breathing out and you forcing the breath, moving the nitrogen from the lungs. And this is why the lung on the left may well have an SPM from the lungs. And this is why the lung on the left may well have an SPM. And then I see a lot of people forget about, you're pre-oxygenating your patient, and you say, well, I'm going to have to intubate a PD. I see a lot of people forget about, you're pre-oxygenating your patient, and you say, well, I'm going to have to intubate a PD. They're breathing like crap. What position do they put the patient flat when we're pre-oxygenating them? They're breathing like crap. What position do they put the patient flat when we're pre-oxygenating them? Put him up about 20 to 30, but we'll see if we can get it here. About 20 to 30, but we'll see if we can get it here. The end of a breath, and we want a little bit of pressure in there. You put the second breath into the balloon, and all of the force acting against you to get that first breath, and you pop the balloon and all of the force acting against you to get that first breath, and you pop the balloon open just a little bit, and they're stuck in this cycle where we're never really already in the balloon, and we were just essentially giving that second breath of pressure in there, and now you've moved them over to this cycle where you're able to use. Yeah, CPAP. There's another one you can use too. I don't know, you all may, especially if you have that patient who's like at that. Yeah, like I said, if I'm bagging somebody, as soon as you realize that you're going to intubate the patient, just go ahead and put on whatever you're doing and then get your stuff together. 65-year-old female, she has a history of COPD. Her SpO2 is 82% on a non-rebreather. She's in obvious distress. You're in intubation. You have them all drawn up. I think you all waited for that first. Yeah. And you can mix them a little bit too, right? One very wrong answer here, and I'm glad nobody picked it. for a terrible intubation. These are the patients who, as soon as you take abort intubation, I was kind of hoping somebody would in this situation, then yeah, you may be able to hold them off for a minute. That are really high risk when I'm intubating them. It's really that whole volume that we're worried about when they stop breathing. Your belly is pushing up. They're pushing on their diaphragm, not letting these, like this patient, has scarring of their lungs. They have already collapsed. The techniques that we can use, though, for these patients, airway adjuncts, like our % mark. CPAP or BiPAP, it's great. We also forget about it. Gotten pretty big in the emergency medicine world. Perfect. Up to 15 liters. And with this, it's pretty theoretical. There's some studies that lungs. You're just trying to buy a little bit more of that safe apnea time. All my intubations now.
For children that have been oxygenation.
Awesome. Thank you.
In the EMS literature yet, but anesthesia, this actually gives you 5 of PEEP. And so now you have PEEP on top of that during a certain type of high flow nasal cannula. So
Just leave our high flow.
yeah.
While we're prepping and doing
And it's
it.
in us to do it in the ED. So we can.
There's that idea, and so it's because it was a little secret. I think oxygenate this person. I didn't tell people, and so if you could share that with the truck.
Put them on a nasal cannula. Don't turn it up to this the other day, and they cranked them up on 15 while they were wide awake. And as soon as if you're going to push your medicines or right before you intubate, just. I kind of already killed the after you get your interall in emergency medicine and pre-hospital when we're inpatient. Liters non-rebreather. If they're looking like they're having a hard time breathing, I personally away at that 3 minutes. If they're dropping below 95%, they're going to be a really difficult intubation, or they're 21 and I do it. How is this patient going to do? How risky is this going to be? And that's it. Any questions? No 28 hours of sleep you can't pay perfect attention to hit it the second.
Raise your chair, here, another freestyle. Sound good? Then we'll do the asthma. So that way we see. Doing the same.
What's sure exactly what we're doing?
Is there enough?
Yep.
We want to split them up into groups so
I told them to come back. And if you need to, we'll force them into groups to assimilate, or even make a fourth if we need to. Well today. Happy? I think so. Thanks, man. Yeah, thanks. So I didn't realize. I would love to get a regular medical student and make it some sort of like longitudinal where they work with this, and they kind of organize like the social media and the exercise and all like that.
Yeah, I had no team, so I
Gotta find that. That way I've got somebody who for like years.
Yeah.
Yeah.
Yeah, because you know if you ask them, are you going to be involved? Oh, yeah, absolutely.
Like them before they realize.
Yeah.
So Nick, we'll do the peaks first, that way they can get out, and then we'll get the other two done. Thank you. Appreciate your flexibility and patience. As long as it's not Washington, it's a bill, I'm happy. I got you. Have 3 minutes ahead of Apple time, and every year it kind of just gets us back a little bit ahead.
Yeah. My G-Shock does that every now and then.
It's the radio frequency or something, it resets to that or something.
But it will correct itself again now and then. Yeah, mine will correct itself if I connect it.
Oh, mine's not smart.
Yeah.
Mine just, I think it automatically syncs to the radio or whatever, but it's like 3 minutes different from Apple. Like when you call code, you gotta do that. Yeah, that's what I'm saying. Whenever they get there,
Like Clark, I swear that to me. Every time I call time of death, I look at a different clock, and I'm like, time of death 9:43, and they're like, no, it's 9:44.
This is my
like they have their own
this is my time of death. This is my time of death every time. This is my time of death, and then my post-paralytic. Like Don, I haven't heard of them. They're
it looks like a turtle from Seiko.
Yeah, it is a. It's a dive watch. It's one of the first dive watches. So there was an author named Clive Cussler.
Yeah.
You know Clive Cussler?
Yeah.
Okay, so
I
I
read
grew
it
up.
when I was a kid.
So I grew up reading all of his Dirk Pitt. Yeah, all of his. So his watch
Was it always? Oh, was it?
It was, and
I was
it was
younger
this,
now.
it was this Thompson.
Awesome.
So I was a huge fan of all of those books, and so I told myself when I graduated residency, I would buy myself
Nice.
And so
Very cool.
So-
Did he die? Do you know?
Yeah.
But
He died.
his books are still going, right?
Yeah, books are still going.
Because he's got two people who are writing
So
books.
he does. He has a couple of people, and he also has his son.
Oh, that's
So
cool.
yeah.
Neat. It's gotta be a rap. Have to think over your dad's legacy.
Yeah. Yeah, Dirk Pitt's.
That was like the last book I read for fun. Like, I had an interview question. I read this about the last time I read a book for fun. I was like, yeah, it's like 8th grade. Couldn't think of the name of the book. I was like, well, let's interview something with fun.
Well, this one sideways. I don't really think it's fun. I have a machine.
That's all we need.
That's right.
You don't need anything else.
Program director asked me, he said, well, I see you're involved with neurology. What do you feel like is one of the biggest issues, or one of the biggest hot topics in emergency medicine? And it was every meeting at that point was about the job.
Right.
And how it was like,
Yeah.
probably not the best representation. So I said, thank God I didn't go into it too much. He goes, oh. Yeah, you wrote the jobs report?
Oh.
Yep, it was it. We spent the rest of the interview with him defending his jobs report.
You know, I did notice your name was familiar.
My worst one was the program director showed a video, and he's like, yeah, I made this video last year, and then like looking at him versus a year ago, he would look like at age 25 years. And then during the interview, during my like time with him, his exact quote was, "Please come here." And I was like,
Please be my friend.
No, I'm not. Like the whole time it was super
Twilight song. You're not.
Down. Reaction.
What's the one that?
4 is the one that's boxed.
I tried to both ways.
Your free hand.
What's that now? Hey. Another lock box.
Ultraviolet light.
Once.
Equipment.
In this room.
Okay. Two portions. The second strike with 100 straw. Draw number. We'll try that first. Okay. No. I love it. They have now ultra. And that dosage of 34.
Rule out threes to where blood or T flow. Next thing.
All right, instructions for free. Into the bags.
Little different about this, especially in this appropriate. Yeah. What's the check? Okay. Or the VM and stuff. This is not going to work again. The other one, and then moving to the blades and then I draw instruction out. So just kind of explain that all that how that flow in something like this that's a creative way, and that you're probably never going to forget 20 of Automate and 100 of Sucks ever again.
Definitely interesting.
Apparently, we're gonna have to make this part of every one of Good. Well, that ends the scenario. How quickly can you get through yours? Ready.
Matt, he's got a concerned family member today.
Yeah, I'll Okay.
Right up there. I need you to get up.
It's traumatic.
Yeah, they.
Made Michael Jackson go to sleep, and that's about all it's good.
And I don't know when I'm non-stop cough. 5 rounds, super teasing, and then just please don't intervene. Had like a hereditary angio talking. Yeah, they were down.
I love it.
Just start with like heart rate of 226. And the SPO started like 80.
So let's do 220 over 150.
That's fine.
158. What?
You can do like 80%.
80, so we'll do cyanosis. That sounds good to you. Respiratory rate. I'm just kidding.
I don't want him to just straight up intubate him from the beginning. Ideally, like them to CPAP, nitro. And then eventually intubate him. You can just call the scenario down and do that.
Alright, 124. So eventually I'll get instead of using 2 different devices. Of course, pressure doesn't matter. We're not doing manual blood pressure.
So I thought about like the ice packs that have the gel in them. Put it on the patient, whatever, and just wrap it in socks or skin. Putting another one in from my cooler to the freezer. Just throw that in every now and then. When they go to all right, let's see here. Mostly ambulance drivers today, right? So let's switch this over to the 35. I had to plug up. I'm stupid, and I put them in standby mode, and I didn't turn them off, so I have to have them plugged up. So nobody trip.
I don't know, but I'm looking for the video. I'm looking for the video. Tell me this is the problem.
I wonder why. Alright, I'll kind of give you an overview here. If you all want to kind of pile in the front and the side. So this is SimMan. Essentially, you want to pretend like he is a real. The evaluators will help. You can list points. He has a carotid, a radial, and a femoral pulse. They're all on that left side. The right side, you have pre-spiked and ringers, whatever one you want to put. You hook them up. Our medications are over here, okay? And there. A lot of the medications we use are live medications that are expired. Okay? As much as you want, as little as you want. If you need any kind of airway management or you don't know where some but with this, if you use something like a BVM, or if your airway gets dirty, or you find the need to suction, suction's right here. Nothing is out of play, right? If you're going to do something potentially stop you. If you have to use needles, they are here, and there's some. Okay, if you have an ampule that you want to break, these are simulated ampules. And look pretty about them. Draw up what you need. There's a multitude of different syringes up here. As far as airway management, here's some laryngoscope blades right here. Skin. It's like 90% accurate. Things as you touch, you can actually move this around. It's a move it around. If you want to put somebody on the monitor, if you want to put pads, if you want a 12 lead, it's all right here. Is in here as well for intubated patients. If you want pulse ox, it's over here. In order to get a blood pressure, does that make sense? So, plugged up, so if you're moving around the back of the truck, try not to trip on it. I'll step off and I will let whoever the
We're gonna have to wrap around to the other side of the patient. All right, so 2-year-old guy, he for trouble breathing. That's all you got. You went ahead, you got him inside. Struggling, he can barely talk. He just really doesn't look good. Because the house is a little too full. He's a hoarder. And here you are. Ask whatever you want. Do whatever you need to do. I'll be your patient. I'm breathing. If his rails are wrong, okay. The end of the bench on this side. Gotcha. Perfect. Get his never ready. Just be on safe side. Yeah.
He's 79%.
Perfect.
It's a good flow.
CPAP.
Problems on Capno real quick too before we put on the CPAP. It's been kind of getting worse. Today it's been really bad. Heart.
Tight.
Okay. I don't know what they call it. I've been. I don't know the name of them. They're inside somewhere.
Do you take something that helps you?
Both. Okay. Both. It's a bunch. I'm feeling. This is new.
Do we notice anything like that?
Yeah.
On his hands, feet, face.
No real ascites.
Sarah, is this swelling in your hands and feet normal for you? Or anywhere?
We can't get it under control.
Okay.
We've been trying.
Okay, fair.
Is he breathing?
Do you accept the CPAP okay?
All right.
Resolve
Any
visible
pulse?
to rise and fall.
No pulse. Initiating.
You want to replace these with
Give me
pads.
pads. Intubate. Or is it actually hold on intubation, assisted vent. I'm just very empty airway.
I'm gonna hold for a rhythm check.
Do we have carotid? I have a radial pulse.
Radial, okay.
Alright, what are you doing now? Do you have an LPA or an LPA?
Not yet. She's working on getting one.
Perfect. NPAs, OPAs.
I'm not even scream. There's a.
Okay, so
Should be up there if there are any.
alright.
OPA.
Wow. Not a reaver, just to try to do that, and then we'll try to go over for. Perfect.
Yeah.
We have antenna on.
The blood pressure is super high.
Sir?
Do we have a painful stimuli?
Go for now.
Alright, let's go ahead and start assisted ventilation again.
Hey y'all, what's going on? Who y'all got back here?
Hey,
Is
so
this Mr. Jimmy? He's breathing.
Right now we're doing okay.
It doesn't. I got you though.
I was gonna say it's all no.
49. Alright, we're still doing good there.
Okay.
It's showing. I was gonna say you're good.
It's still reading.
Are we just gonna read it off? Okay.
Alright, that's fine. So, first I switch back over to BVM if possible. So, Pap, he's super high there. Did we establish if he has any rails? Does have
Well,
some?
Wheezy and rails. He's got all.
Alright, sounds good.
all
Does
the
anybody
senses.
want on that right now until we get oxygenation up?
Let's get. And then I would go for the. Or we can do simultaneously.
Was it?
We've got enough hands. We can do it.
Yeah, I was gonna say we'll do simultaneously
hold
as
still.
of do a blood pressure check to be on the safe side because hopefully it's actually that high. IV stuff just establish a line.
Okay, keep in mind the fluid's already there.
I was gonna say I'm not doing any fluids right now. I just
still super high. Pretty much oxygen's up, not much up. Reactive. So let's pre-oxygenate. I mean, can I have you just get oxygen? Oh, okay, we're good.
Sounds like sluttery vomit.
Ready? No PACs. No. Stop it now. It's okay, sir.
Once every couple months. Been ventilated before and has had multiple stays inside the hospital. Does not like to take it and possibly has not had his medication in over a month.
We're still oxygenating. He's still getting intubation stuff all ready to go.
No, not at the service.
Okay.
So we don't need.
But you may
No mask. Reason.
Nope.
What? No.
Nope.
Lame. Okay, that's fine. So, our pulse rate is going down. Nitro paste on?
No, we did not.
Okay. So usually whenever that's going down. Okay. So we're still breathing from there. Is there anything else I'm missing?
Just dropping. Heart rate
Heart rate dropping. Blood pressure.
Alright, I was gonna say.
So no.
That was a me issue. My
Okay.
bad.
Oh god.
Heart rate's still going down.
I think he's about to rest again.
Pads are still on if we need to.
Turn the siren on if you want. Really get it out there.
Oh. Does he have a pulse at this rhythm? Somebody feel?
I was gonna say. Alright, yeah. I was gonna say, go ahead and set up a tube. Can I have another person just get that ready?
Thomas tube holder. You can't secure a nasal tube without 12 tape.
What's going on with Jimmy? What's going on?
Jimmy's not doing.
State certified.
We are out there now. Thank you, sir.
If y'all need anything, I'll take your medicine. Do you know if he has any family around anywhere?
Let's go ahead and do that. I said, it's mainly oxygenation that we're.
I think so. Let's
Go ahead and just.
we'll go try to find his mess. You stay strong, Jimmy.
First dose of Epi's in at 10:44.
Just for fun, I've got a feedback.
You need to switch, let us know.
Sheets or anything? Sheets what?
Just be on the safe
Proper
side. Go ahead and
positioning
pre-charge.
Oh, okay, so.
Alright. Pulse. No pulse.
Clear.
Shock. Probably should just during all this.
Hey, his guy title's going up.
Hey.
48. Can we check the pulse?
Can you check a pulse?
Shout.
I am good right now. So are we ready to intubate? Pause, or are you good right there,
No,
sir?
turn-
What you
oh.
need there, sorry.
You have IV access.
Have we given any?
Is it plugged in on the
Yeah.
other side?
Yeah. There we go.
Right there. Can we hit the suction?
right.
7-0 at 20.
Yeah, and like a flash pulmonary edema. You
Yep.
had it. You had it. So we did great with getting the oxygen on early. We talked about medicine.
I mean, it was just more of thinking about just that.
Airway, right? 'Cause
Yeah.
you're going to vasodilate, let that fluid start coming. Yeah, so I would have done the nitro pace.
Yep.
If you have any drips that you can do or pushes. So nitro paste works fine, and that's what I do in the ED too when I'm putting somebody on a drip. Put some paste on them or give them some. You can even do sublingual.
Somebody that has spray nitro.
Yeah.
So
Yeah.
You can do that.
Start that on these people. What do you all think you did well?
Oh yeah.
Yeah.
That's pretty good.
Yeah. I agree.
Pace.
Yeah.
Just try to knock everything down first.
The CPAP is usually just I have to already bag them like for that BiPAP, that extra pressure.
Great candidates. This is who CPAP was made for.
Yeah.
Were these people? Because you're also. I'm sorry.
Well, they were.
Curious question. I don't even know if we know.
And CPAP or BiPAP was not going on quick enough for me, so that's why I wanted to throw at least. He needs pressure. It was more of something, in my personal opinion. So.
Yeah. This is me standing in the back and getting to watch every little thing and also making the scenario. That's still acting as a non-rebreather right there, but now I bag with it.
Right.
And I would have been bagging the patient the whole time, especially if you've done compressions on. They're gonna head towards the tube when you get to the hospital anyway. So go ahead and start bagging them out.
Did you all know this? Was
Anything else, Luke?
Yeah, from back here.
Put the BVM straight in there.
From back
I've done
here.
that.
Also
switching
had a
everything
little
up,
bit of
you just
information.
leave it.
It's like you pull me aside. Me interject every couple of seconds. You pulled me aside. I could provide, and then sent me to go look for meds, which. So if you can send somebody, you're like, hey, go with this. Medication wise for you. Yeah, so because I was annoyed and being y'all's way a little bit, but quickly corralled me because I was going to be a lot more annoying.
I thought
than
you
he had
were.
pulled me.
Yeah, like 30.
Yeah, he immediately like grabbed.
No matter what you all did, he was going to code anyway. Seb is way.
The first time, he actually didn't go.
If the patient died, you failed.
Yeah. We do it great.
Not right now. The first time, I was like, yeah, if you didn't read your code.
No, like getting everybody to be like, hey Jimmy.
But for like the next one. Oh.
I had a feeling.
I forgot.
Yeah. Especially if you don't know what's going on.
I think we just verbalized it.
They run with 5 people.
Oh, God.
Or engine.
I'll take that.
Getting one person to be like, hey, come with me. Let's go try to find some meds. Let's go.
You learn how to use the software and stuff with it. Low tech, and I'm really proud of it. I found a way to
Representing family, it's your job to segue them. Yeah.
So when this is done, fill it, and I'll make it look like new.
Yeah. You don't need to think about.
I don't know where.
What?
Here's some
You didn't do that.
I don't know what.
The point where they have the drugs.
Pretty cool.
And
There's plenty of accommodate 100%.
Second shelf, second over.
Say that? Yeah, I said that like 9 times. Did you Sir. I was coming out of first care, and every nurse and you.
And some they're like,
we don't do investigation.
they're like, whatever,
No,
just
it's not
make it
an
happen.
investigation.
Eventually, there's going to be a.
Like you could be in the next room and you put on Simplex or something.
So the goal is that.
How rugged is this thing?
Not super rugged.
In the bathroom or whatever.
Yep. They just got to be to do needle decompression, put chest tubes in on them. He's got the genitalia this after the fact. So. Anybody looked at his pupils, they change. So this is the base model of them, but they have them to where they do for like teaching scenarios. I literally can just. You can. You can. This stretcher comes out. We used to.
Hey, this is what. We were tell you that. Exactly. Where was it? St. James. Who lives in St. James?
Real quiet when I filled that up. Where'd the box go?
You're gonna kill somebody, and you're never gonna forget it. I don't know if I did the locks right. Now that I think about it.
Because it's listed.
Yeah, I don't doubt. Broad. Like our mountain is pretty broad. We don't have some jackass lawyer who's like, well, I just see patients in the field.
They're finishing up their other sim. They won't be able to cheat.
You're in that picture.
Hiroshima. And here it is.
We'll see how that goes.
Matua lollipop.
How'd it go?
Here at Front Creek, everybody just died.
I remember Fat Jason 20 years ago.
Jason Carlisle?
Oh yeah, Jason.
Alright. Really?
Yeah, he's skinny. Yeah, he's skinny now.
That's what I did after when the next COVID hit you leave on for.
So your final work is 100 kilos. I'm 100 kilos.
Strategic. If I go up 5 pounds, I go hit the treadmill. If I lose 5 pounds.
Yeah.